And with that, we'll kick off our session with our first presentation by Arash Faridoni, The Impact of Integrated Vascular Surgery Residency Training Pathway and Professional Development Time on Career Choice and Research Productivity.
Good morning. Thank you, CVS, for the opportunity to present our work. We have no relevant disclosures. Since the advent of integrated vascular surgery residency in 2008, there has been a steady increase in the number of the programs. From 2012, with 46 spots and 93 spots in 2023, there has been a near doubling of integrated vascular surgery residency positions over the past decade. Integrated vascular residency programs are thought to allow for earlier specialization and increased time spent on skills, knowledge, and research that is specific to vascular surgery. Some programs have also added optional or mandatory professional development time to allow trainees delve deeper into research and lay foundations for future academic pursuits if that is of interest to them. Several subspecialties have looked at the impact of different factors that may push people into academic employment, but nobody has studied this in vascular surgery. Therefore, the objective of our study was to compare vascular surgery fellowship and residency programs to see what factors impact the trainees into their eventual career paths. To also provide guidance for trainees who are interested in academic careers and provide information for program leaders who are trying to best prepare their graduates for future academic employment and greater research productivity. Our first hypothesis was that integrated vascular surgery programs lead to more academic employment and increased research productivity when compared to vascular surgery fellowships. Upon review and approval, APDVS provided us with a list of graduates from vascular surgery fellowships and integrated programs. Thank you, APDVS, for your support. And we performed a retrospective analysis of the graduates from 2013 to 2017 from both programs. We looked at many individual and program variables that are listed here and will be reviewed throughout this presentation. We used the publicly available sources such as Doximity, Scopus, PubMed, NIH eReporter, LinkedIn, and institutional websites. Here's an example. We took a look at Dr. Sheehan's lackluster career trajectory. We found that Dr. Sheehan is currently a professor of surgery, program director, and a chair of vascular surgery at LSU. He did his fellowship at Beth Israel. He has published 42 papers with a timeline listed here on PubMed and has an H index of 16. Dr. Sheehan, I'm still waiting for my Doximity friend request. The analysis gave us nearly 734 graduates from 2013 to 2017, 600 of whom attended vascular surgery fellowships and 130 integrated programs. Of these, nearly a third were women, and there were about 134 active programs during this time. 120 of these had fellowships and 69 integrated programs. Our initial comparison of the demographics of both groups showed that graduates of the integrated programs were more likely to have a higher female representation, to have graduated from allopathic programs, to have attended training in the Northeast, hold advanced degrees, and have attended larger programs. On the other hand, graduates of the fellowship were more likely to have trained in the South and come from top NIH-funded programs. Notably, there was no difference with regards to number of publications by the end of training between the two groups. We also wanted to test the hypothesis that each generation and class of vascular surgery graduates is publishing more and becoming more competitive. However, this turned out to be not the case. There was no difference in the annual trend in the average number of publications by each graduating class in vascular surgery. And there was also no difference between the graduates of fellowship and integrated programs. When comparing the two groups with regards to practice, there was no difference. Both groups had equal representation in the mode of practice, academic affiliation, and region of practice. And this is probably the most important slide of this presentation. when comparing the two groups, the graduates of the integrated programs were more likely to leave academic medicine, and if they were in academics, they were more likely to have stayed at the program that they trained for vascular surgery. But most importantly, there was no difference between the two groups with regards to the number of publications after training, no difference with regards to annual publishing rate, no difference with regards to NIH funding, no difference in H-index, no difference in leadership positions or their current faculty position. Next, we wanted to test our second hypothesis, which was addition of professional development time to integrated programs has led to academic employment and increased research productivity. Comparing the graduates of programs with and without professional development time showed us those who had attended professional development time were more likely to be female, more likely to have advanced degrees, come from larger programs, have higher number of publications by the end of their training, and have attended top NIH-funded surgery programs. Those who have attended professional development time, programs with professional development time were more likely to be in academics, whereas those who had attended those without protected time for research or professional development were more likely to be in private practice. Those with programs of professional development time were more likely to hold academic affiliations. And lastly, those graduates from professional development time programs were more likely to have higher number of publications after training, higher publishing rate, higher H-index, and there was also a trend towards acquiring NIH funding as attending amongst these graduates, but this did not reach the statistical significance. To summarize, graduates of both integrated residency and fellowship programs have comparable academic employment and scholarly productivity. Moreover, professional development time during integrated programs correlates with an eventual academic career and greater research productivity. The study supports maintaining support for both training paradigms and investing in professional development time to develop academic surgeons. Of course, further research is needed to better understand how different training pathways lead to career success in different practice settings beyond the simple metrics of scholarly productivity, which was the main focus of this study. Thank you for your attention, and I'd be happy to answer any questions.
So while we're waiting for some people to come up, so the surgeons who left academic medicine, did they still stay in medicine and in vascular and go to private practice, or did they leave medicine altogether? Do you have data on that?
We did not specifically look what type of career path they embarked on, but based on anecdotal or memory, I don't think there were anyone who had left surgery.
Linda Harris. So I enjoyed your presentation. Question, do you think it's really, which comes first in a sense? It's a chicken and egg question. Is it individuals who want to go into academics are the ones who do that extra year, or is it that doing the year creates academicians? Because that may make a difference in how important having that academic year is for future development. And you might also look for the fellowship and how many did that academic year during general surgical residency. Because I would suspect that people who have a motivation towards academia, whether it's Masters of Public Health or PhD or whatever it is, take that extra year to develop more. Thanks.
Thank you very much for this excellent question. Completely agree. It's hard to know if this whole process is selecting for people who are interested in academics in the first place, and they apply and tend to train at programs that have protected time for research. But also, the fact that academic programs tend to be more competitive and fewer spots that in integrated programs that provide the additional protected time for research says something about that some of these people who might be interested in research might not end up in a program that has protected time for research. It would be interesting to do a survey of these students and look at their career trajectory after they have started residency and see whether they were in a program that had professional development time impacted their career choice.
Yeah, quick question. Alan Lumsden, Houston, Texas. Do you have a sense of how many programs have mandatory research built into it versus voluntary research? One of the things that we really struggled with, we used to have mandatory 2 years When you cut it down to 1 year, now it's like, you want to do it, we'll figure it out. And does it make a difference?
I think at this past application cycle, about 10 or so programs had mandatory professional development time, and I think another 5 or 6 had optional. And then I think there are 1 or 2 that have only 1 year of research, but that's something that we should certainly look at for manuscript purposes, because it's an important factor, because I don't think there are that many programs within vascular compared to other surgical subspecialties that provide professional development time.
Dr. Ferridoni, that was really nice. Thanks for your presentation. I have 2 questions, because as you've shown, about 40-some% of our graduates aren't going into a classically academic practice. And I recall survey data through the APDVS almost a decade ago now that highlighted there was a desire from the trainees to have more protected time. And so my question for you is really, 1, can you make any comments on your fellows and whether they had academic development commitments during their general surgery training, which does in fact carry over? And 2, what do you think the trainees want right now, and do we have to coach academic development for all of them, because we clearly need all types in our workforce? Thank you.
Thank you for the thoughtful question. To Dr. Lumsden's point, Dr. Harris's point, there are people who have attended programs that provided them with the time for professional development during their general surgery training. And in our analysis, we had a variable that looked at previous time for professional development time. So what that meant for vascular fellows, they did that either during residency or medical school, or for integrated residents, that meant they had to do it during their medical school. And my colleague, Dr. Fisher, presented a separate analysis of this during a VEST meeting. And in her analysis, she found out that actually research during either general surgery or medical school was predictive of people ending up in academic practices. No, I don't think that all programs should be investing in academic employment if this is not in line with their mission. There are programs that are more community practice focused. There are programs that don't have different values and different objectives for their trainees. And I think, as it was pointed out earlier, some of these programs may be self-selecting, or applicants may be self-selecting for which programs they apply to. And the goal of the study was to not promote creating academic surgeons across the country, rather than finding which training pathways are more productive when it comes to producing academic surgeons, so that trainees who are interested in following careers in academia can focus on those factors and promote them. Thank you very much.
Our next presenter is Camilla Villacresces, and she will be discussing definition and perception of autonomy in vascular surgery training. This is a special multi-institution study from MUSC, Mass General, and University of South Florida.
Good morning. Thank you for the opportunity to present. For some background, there are currently several general surgery studies that link a lack of autonomy as a major contributor to low self-confidence in the ability to operate independently after residency graduation. However, there is a lack of current data regarding the perception of operative autonomy within vascular surgery training. The objective of our study was to determine where discrepancies exist between attendings and trainees in the definition of autonomy within the patient care timeline. We achieved this through an IRB-approved anonymous survey that we sent to all vascular surgery trainees and attendings across the country. The survey was broken down by PGY level for the trainees and assessment of each PGY level by attendings. The breakdown of our questions can be seen here. The patient care timeline is broken down into pre, intra, and post-operative skills that were asked to be ranked by level of importance by trainees and attendings. The major differences that we found between trainee and attending answers can be seen here in blue boxes. At the intern level, case planning was found to be the most important preoperative skill by 100% of interns, and initial incision was found to be the most important intraoperative skill by the majority of interns. Both of these were found to be less important for interns by attending answers. For mid-levels, the initial consult visit and case planning were ranked as most important by the majority at the preoperative level. The initial incision and exposure of critical structures were most important intraoperatively. Again, these were not found to be as important for mid-levels by attending answers. For chiefs, case planning was marked as most important preoperatively and exposure of critical structures intraoperatively. Attendings did not find these as important for chiefs. And at the fellow level, the only difference was found postoperatively, with dictation of case being marked as least important by the majority of fellows and most important by the majority of attendings. Finally, an additional interesting finding that we saw in our result was in relation to double scrubbing. There was a significant difference in trainee answers across different regions about this being the most important intraoperative skill. However, when we asked trainees if double scrubbing itself was inherently important to autonomy, the majority answered yes amongst all regions. But when we asked trainees how often they double scrub cases, the majority stated that they do so less than 25% of the time. In conclusion, there are several discrepancies between trainee and attending answers to skills important to autonomy. However, as trainees progress, their answers start to mirror attendings. Specifically, trainees at the junior level want to be involved in preoperative management and planning of cases for their autonomy. And despite trainee sentiments of its inherent value, double scrubbing cases is rarely done nationally and at all levels of training. Further evaluation on how to integrate these skills formally into educational curriculums for vascular surgery training programs should be done. Specifically, more involvement of junior level trainees in preoperative planning and management should be looked into. I'd like to thank MUSC and all of our collaborators for their contributions to this project.
So the double scrubbing thing is interesting, right? Because I think that was an inherent part of my surgery training as an intern, and I think we're getting away from that. I kind of blame Epic a bit for that, as you know, interns are spending more and more time in front of the computers doing various things like that. So I didn't see your survey, but did you dive into the reasons for why they do what they do, and you know, do they not double scrub because of reasons of time, or is it they didn't find it valuable to their training, or you know, is there a disconnect there?
Yeah, so that's a great question. I think we didn't specifically ask further into why double scrubbing might not be done as often, but I do think that it's mostly based on a lack of time, especially for the junior level residents at the intern at that mid-level once they start seeing consults. And so I think it would be interesting to look further also into institutions that have more of an APP support for that too, to see if those have higher double scrubbing percentages.
Dr. Lee?
Yeah, very nicely presented. I'm curious about the result that everybody clamors for more time to do operative planning, case planning, pre-op planning. I think the faculty and the practitioners in the room know that a lot of that happens in between cases at 6, 7, 8 o'clock in the evening. And I'm curious from your trainee perspective when you think you might wedge that in to spend time with us, because I think in between cases, everybody's running around finishing their Epic lists, checking off on, you know, pre-op, post-op orders, getting the next patient ready. And that's when a lot of that pre-op planning for tomorrow's case goes on. Mm-hmm. Do you have a creative solution to help us find the time that we can all sit together to plan out things?
Yes, thank you for that question. So I think that that's part of the formal integration into educational curriculums, specifically looking at those junior level residents and knowing when cases are planned, having time that is integrated, ahead of those cases, not necessarily the day before or the day of. I know one thing that we do at MUSC is when some of our attendings talk to us, for example, that Sunday, the week before, about possible planning for cases that we know are going to happen. And so I think it's, for cases that are planned, more of a looking to it days ahead of time.
We can squeeze in one more question.
Yeah, Michael Scroy from Stanford. I really enjoyed your presentation. I do have one comment and question. You know, when it comes to case planning and autonomy, particularly for the junior residents, and that's what they're looking for, where do you try to bring in surgical simulation where there is an opportunity to actually do case planning that might not be on the patient in the hospital, but actually putting that part of your curriculum to encourage them to participate a little bit more and feel like they're actually taking care of patients that are going to the operating room?
Yeah, that's a great question. That's not something that we specifically looked into, but I think is a great point. I think that trainees in general want to be more involved in simulation, and I think that is also an opportunity at the more junior level to start to learn how to integrate those skills before you start to operate more as a chief. So I think that integrating that in the earlier years would also be something to look at.
Thank you. Great job.
Thank you.
We're going to bring up Dr. Vayuka from Mount Sinai. She has a special invited presentation on this topic, understanding and addressing varying perceptions of autonomy.
Good morning. I want to thank the program committee for inviting me to give this talk. I have no disclosures. So autonomy in surgical training, as already was shown by the previous presenters, it's a very important thing because it allows graduate independence in the operating room, improves operating skills, builds confidence, and it's an important factor for the smooth transition of the residents from the trainee level to a full-fledged surgeon who can work independent. There are many factors influencing autonomy. Some of them is the resident's level of training and competence, a case complexity, attending resident relationship is a very important factor, duty hours, OR efficiency, hospital policies and demands for productivity, and public perception of residents' role in the OR. Public perception is shaped according to false information that circulates in media and sensuous TV series. And in this, there is a survey that was performed in US with more than 2,000 responders, where only 1/5 of these responders, they were agreeable to have a resident operate on them only with supervision, when the rest of them, they had a pretty dramatic negative response. However, it seems that education, correct education, can change this perception, as shown in this little study from Texas, where the authors, they managed with education to increase the percentage of the patients that were willing to have to be operated by residents from 52% to 65% after education. There is evidence, some comes from vascular papers, that for both residents and faculty, the most important factor to grant autonomy is attending a trainee familiarity that leads to entrustment and resident preparation. Entrustment is key in training, and it's based on clinical skills and proficiency of the resident. However, the fragmentary nature of faculty-resident interaction that occurs very often today makes this assessment sometimes very difficult. And in these cases, the attending bases their assessment on personal biases about competence, honesty, and confidence. They are associated sometimes with just some certain facial features, cultural features, personality, gender, and etc. For the surgeons, there are two main types of personalities. One is the promotion-oriented individuals, so they are playing to win, and this is traditionally was the typical surgical personality. The second personality is the prevention-oriented individuals, that they play not to lose. The traits of this personality are more commonly seen in female surgeons, and some of these traits usually they misunderstood as lack of confidence or competence, which is not supported by any data in literature, when what data support is the alignment of these personalities between a resident and attending in the OR is associated with increased interoperative entrustment because both attending and a resident, then they share same goals. And they affirm each other actions and approach in the operating room. The subject now of perception, gender-related perception and autonomy is kind of tricky and has evolved, thankfully, to the right direction over the years. In 2014, Teman et al., they identified a very hazy relationship between resident gender and perceived resident skills that connects the otherwise distinct factors of operative autonomy. And later on, in 2019, Zerul et al., after reviewing the residence evaluation, they demonstrated that females were less likely to achieve acknowledgement for their performance and their career potential compared to their male counterparts. So there must be a bias or the hypothesis that there is a gender-related bias or different perception when it comes to the resident's performance is the hypothesis of this paper, where the authors, they actually compare the fundamentals of laparoscopic surgery score, which is a very objective measure of performance, to the quite subjective technical skill score that was given to the residents by the attending surgeons in the institution, in 3 different groups, male, females, and underrepresented minorities. What they found is that when they compare the kappa correlation coefficient between male and females, females had way lower kappa correlated coefficient, and the negative value signifying there was no agreement at all between the objective and the subjective score. There was agreement, fair agreement for the male residents, and there was no difference in the coefficient between the different ethnic and racial groups. And a funny observation was also that there was no evidence that the female attendings evaluated female residents different than male attendings. So that difference, gender-related difference in perceptions about clinical performance may explain the difference, the disparity, gender-related disparity in autonomy. That was shown by this paper, which actually has been cited by many, where the authors, they explored difference in the degree of autonomy granted to male and female general surgery residents as perceived by both faculty, which is the upper graph, and the residents at the lower graph. The degree fluctuated between no autonomy at all to the highest degree of autonomy when there was only supervision. And as you can see, both faculty and resident, they agreed that the highest degree of autonomy was less likely to be given to females, which is the gray bar, and more likely to be given to males. This difference was more prominent at the residence evaluation. When the analysis was stratified by the year of training, this gender-related gap on autonomy, according to the faculty perception, disappeared the last year, but according to the resident perception, continued throughout the whole training, even in the last year. And again, a very interesting observation here was that according to the resident perception, more autonomy to male residents was given from both male and female attendings, when according to the faculty perception, more autonomy to male residents was given by male faculty, but there was no gender-related difference in autonomy granted by female faculty. There is a silver lining on that because it looks like representations corrects these disparities, at least the gender-related disparities in autonomy, as shown in this paper where they compare number of chief, major, and teaching assistant cases between, again, male, females, and underrepresented residents in 2 periods, an early period and a late period. During the late period, that program had gender parity in their system. So what they found it was that females during the early period, they finished with less teaching cases and less chief cases compared to their male counterparts. However, in the second period, when it was gender equality, the two genders were represented equally, there was no difference anymore in the case volume. The underrepresented the minority residents, they still had difference in their case volume as they continue to be underrepresented throughout the whole period. So, in summary, autonomy in surgical training has changed over the years and influenced by a variety of perceptions. I don't really have a golden bullet how to deal with all these perceptions. I was trained to be a surgeon, and like many of us, I learned the trade of the educator on the job. But I have some opinion. I think we should focus on enhancing attending resident familiarity and breaking certain bias about competence and confidence. In order to do that, we have to increase representation in the training programs, have to build structured protocols that they guide in a stepwise fashion attending trainee interaction in the OR to achieve autonomy. Hold regular faculty meetings to discuss resident performance and compare the evaluations among the different members of the families. And from the standpoint of the residents, preparation and preoperative communication with attending is much. Part of this preoperative communication should include negotiation about what part of the surgery they want to do on their own if there are time constraints. Avoid last-minute case assignment because that defeats all the above. Increase interaction with the attending, just to not show up only for the good case. And if you do, don't expect that you're going to get the full autonomy. The residents, they have to focus on behavior alignment in the OR, even if they have different personalities. And that happens after they understand the attending's technique and approach. And to do that, they require to have early exposure to the attending techniques from the first years of their training. Double scrubbing from the intern year, I think, helps on that. Simulation session helps. And finally, patient education in the pre-op area or even better in the clinic probably helps. Thank you. I'm happy to answer questions.
So we do have a session here to discuss, so go ahead.
Hi, Andrew Rogers, University of Buffalo. How much do you think perception of autonomy also has some extrinsic factors from the faculty and resident or trainee interaction, as in relationships to the institution and responsibilities of the institution for preserving and risk management things? You have graduating fellows who are now fully board certified general surgeons who are going into institutions where you might require the faculty to actually be there and present the entire case, even though you're just doing an IND. How would that relate towards perceptions of autonomy?
Yeah, I agree with you, and I have experienced this factor, which is actually different, you think, for surgeons than anesthesiologists, because the resident anesthesiologist can be along the whole case, but dear God, if the attending gets out. So it does affect, and it makes it even more difficult, because if you have to be in the room for a debridement, then you cannot do other things, and I don't have a good solution about that. The only thing we can do is we can discuss more and more these policies with the administration. I have tried that in my institution. I say, for instance, at the timeout, if you expect me to be here, you have to expect the anesthesiologist attending also to be here, and not have the resident, and try to explain to them that this is an easy case, but I think it just needs a lot of conversation. But this is one of the negative influencing factors, in autonomy, all these hospital policies.
Go ahead.
Grayson Pitcher, University of Rochester. There's been a major trend toward EPAs and trustable professional activities over the last couple of years, especially within our society. Is there a role and is there evidence that would improve perceived autonomy or reduce bias?
Well, so far I think this is it's going to happen only in general surgery. It seems that it is a structured program with mobile apps and with just immediate app. So, we have to see, but it has the potential to increase autonomy, because at least we'll guide the resident and the attending what steps they have to take during the case and how should they discuss the case afterwards. And it's going to be more structured program than what it is right now, where you go in with the resident and it's all up to the personality of the attending or the beliefs of the attending to drive the process of the autonomy. So I think it might help.
Yeah, I'll throw myself on that bullet for a second. So one way that the EPA has been, sold to me anyway as a positive factor in training is that, first, all your politics are local and autonomy is going to be decided by your hospital. There's nothing we can really do. But the EPA should give you a framework to go to hospital administration and say, look, this trainee has done this and they can be trusted to, do it somewhat independently. So we'll see how we get there. General surgery is about a year ahead of us, but I think that's, a selling point anyway. Dr. Ait?
Yeah, just a quick question. Appreciate your presentation. My question really relates to gender bias, not just in the attending surgeon-resident relationship, but by the operating room team. And this is just pure, my personal experience, but I think I get more calls from the circulating nurse if I leave a female resident independent in the operating room than if I leave a male resident in operating. And did you have any sense of that female dynamic in the operating room? Because most of the circulators are women.
So there are no good data. There are some papers that they have shown that, women, they receive, female surgeons receive acts of gender-related bias, not only from the surgeons, but by the nurses, by the techs, and etc. It might have to do also that, and I have personal experience on that, this will also change slowly with representation. Because I think nurses also, and maybe nurses, they have more, they grew up, as all of us grew up with certain patterns, who does what, in medicine. Probably the nurses, when they chose that pathway, maybe they had more encouragement to do so because they are females, they have to be nurses. The males, they have to be doctors. So for them, it's also when they see a female doctor, that totally changes their cosmotheory and why they did what they did. I think by increasing the representation, we make it more and more easier for everyone, to see confidence and competence in people that they don't look like us, or if we are nurses, that they look exactly like us, and it's not a curious thing anymore.
I just want to ask the panel, at least in the 5-2 program regarding autonomy, do any one of you give your fellows, because they're already fully fledged surgeons, they have done 5 years of surgical training already, do you give them a title of clinical instructor in surgery or something like that, so that way the administration doesn't get on your back saying that they don't have, somebody has to be present in the, attending has to be present? That's number one question. I want to know if any one of you do that. Number two, this whole autonomy now becomes a little skewed in the endovascular era because the sort of double scrubbing is almost gone. In the endovascular era, the attending and the fellow might do a pretty big case like, TWAR or EWAR, etc. And so the intern may never get to scrub. So what is your comment on that?
Actually, can I answer the second? My opinion, and I feel very strongly about that, I think endovascular procedures are easier to give autonomy because you can have control of the case from the control room, right? Because you see where is the wire, you can direct them, tell them change the catheter, go there, don't go that high, where is your wire? It's more difficult in open cases just because the room is so small and how many. And I think if you leave we do that a lot in our program. The intern or the junior resident scrubs with the chief or the fellow or the senior resident. And, the one takes through the other, in groin puncture, ultrasound, wires, up and over technique. So I do think it's easier because the attending has this, things has a control, been away just by looking at the screen compared to the open cases that you have to be there. You know, you have to look what they are doing. And then it's very easy to put your hand in and take over the case.
Last question.
I think I want to follow up on what Dr. Ike had asked, and I think maybe it's just not just also as far as nurses, not just wait and have more women in OR so they can change. I think what about incorporating that as part of evaluation in each program? Because it does influence how women, residents and young attendings function in the OR. When a team around you questions you, a lot of times you question yourself. When the team around you as a young faculty asks you, do you want your partner again and again and again, you start believing that. And I've seen that in some of the residents, and they come to me and ask. And so the question is, do we need to actually incorporate some of the questionnaires during residency and understand if that pattern exists in our program? And if it does, maybe part of the education is also education for the nurses. Because I don't think it's just a matter of time. There are an integrated part of the education of the residents. And so I'm curious if anyone had any experience doing that, or what do you think about that as part of actionable thing that we actually do and not just wait for it to change?
I think that's a good idea, but I think it's very difficult to break implicit bias just with education. You just have to keep changing the pattern with reality, because we all have good people. They have implicit bias, right? It's a pattern back in our brain. So education, it's a must. But the more women, if there is one woman in the surgical program, and there are many nurses, you know, that woman becomes part of them. You know, why I cannot do that and she can. But if you have a lot of women in the program or a lot of minorities, then it's not something different. You know, they get used to this pattern. So education is good, but I do believe that increasing the representation is the way to go to break these patterns.
That is for sure. I'm not arguing that, but I think that in the meantime, I don't think that one woman in the room should suffer until there are 10 women in the room. And that's kind of like my point about this, is I think as we work more on this DEI work, part of it is hard and it's long term, but a lot of it is hard work immediately. I do think that patterns do need to change, and I do believe that some of it needs to change now. It will be better the more there representation, completely agree with that. But I also don't think that one woman or the two women in the minority room should suffer, or the minority race should suffer while everything changes. We have, as a group, as a majority, the responsibility to actually start making actions, not just waiting for the numbers to change. Because sometimes it's not realistically for the numbers to change, right? There are numbers that you're going to have to know that sometimes it's not going to be 10 women in the room. Sometimes in certain places, because of demographics or other circumstances, there will be only one woman in the room, and that woman shouldn't suffer because we haven't yet gotten to the 10 women in the room. So I do think that maybe that's one thing that we need to think about, how we incorporate it, because that mentality of we have to suffer until something changes, I don't know that it's right anymore, especially if the group of the total, if us, actually agree and believe that it needs to change. So we need to just start changing it now.
Thank you. We do have to move on, but thank you.
Thank you. I'd like to invite now Dr. Helen Potter up on behalf of Dr. Linda Harris at the University of Buffalo and all co-authors to speak on the association between second victim syndrome and burnout.
Good morning. Thank you for the opportunity to present. We have no relevant financial disclosures. The second victim syndrome is an established term which refers to the negative mental and emotional effects experienced following adverse outcomes. Recently, there have been more discussions pertaining to second victim syndrome within the medical and surgical communities, identifying this as a risk factor for depression, anxiety, PTSD, and physicians taking a break or leaving their careers. Many may be aware of this phenomenon anecdotally, but limited guidance remains on how to identify vulnerable physicians, warning signs, or opportunities for assistance. With this background knowledge, our goals were to evaluate the impact of second victim status on physician self-efficacy, burnout, perceived stress, and sleep patterns, as well as to investigate coping mechanisms and desired institutional support by physicians who self-reported as second victims. We conducted this with a voluntary, anonymous survey sent to non-trainee physicians at a university hospital. The survey contained validated scales, including the General Self-Efficacy Scale, the Copenhagen Burnout Inventory, Perceived Stress Scale, and Insomnia Severity Index. We also included individual questions pertaining to second victim status, as well as opportunities for institutional support. Our statistical analyses included a student t-test and a mental Hazel test. The Copenhagen Burnout Inventory, as one of the validated scales used to compare second victims against non-second victims, is a survey which involves 3 domains to evaluate work-related, personal, or client, or in this case, patient-related burnout. The burnout scale answers are then given a numerical value with never or almost never receiving a score of 0, seldom or low degree receiving a score of 25, and so on until 100. Scores within a domain are tallied and averaged, and those with a greater than or equal to 50 points are classified as moderate to severe burnout. Out of 115 total respondents, 74% provided answers regarding their second victim status. 48% were female, 93% were white, 35% were surgeons, and 53% had been in practice for at least 20 years. Of these 85 physicians, 24% reported experiencing second victim syndrome and will now be referred to as second victims. When comparing results to the Copenhagen Burnout Inventory, there was no statistically significant difference in second victim status when evaluated based on work-related or personal burnout. However, those with patient-related burnout were statistically more likely to experience second victim syndrome when calculated using both a Likert scale as well as burnout scale points. Furthermore, those who experienced moderate to severe burnout in all 3 categories, workplace, personal, and patient-related, were statistically more likely to also experience second victim syndrome at 29.2% versus those without second victim syndrome at 9.8%. Specific questions from the patient-related section of the Copenhagen Burnout Inventory were also linked with second victim status, as those who answered often or always to the questions, patients are hard to work with, patients are frustrating, patients drain energy, and wonder how long they can continue to work with patients, were statistically more likely to experience second victim syndrome than those without second victim syndrome. When comparing second victim status against non-second victim status with regards to the General Self-Efficacy Scale, Perceived Stress Scale, and Insomnia Severity Index, those who felt that their goals could be accomplished were more likely to be non-second victims. There was no difference in ability to cope with existing stressors or feelings of lack of control between second victims and non-second victims. However, those who experienced problems with waking too early were more likely to be second victims at 29.2% versus non-second victims at 14.5%. When queried on the top resources desired by those who experience second victim syndrome, the top answers included an official debriefing, individualized counseling with an uninvolved third party, and coaching to cope with the event. The least favored resources were mandatory time off and mandatory meetings with a hospital psychiatrist or psychologist, indicating that counseling is desired but not wanted to be mandatory or perhaps monitored, perhaps for fear of stigma. This slide is a reference from a Journal of American College of Surgery article from 2020 pertaining to second victim syndrome, in which a group of surgeons crafted a peer support program in which peer surgeon supporters were trained in individual intervention plans created for specific circumstances. The results were promising, with 89% reported confidentiality, 73% reported a safe and trusting environment, and 83% reported that this was done in a timely fashion with related to the event. And so as awareness of this phenomenon continues to increase, it's reassuring to know that the framework for a successful program at a tertiary care center within surgeons specifically has been laid. The study is not without limitations. First, this is a lengthy survey. We're reliant on the information the physicians are willing to provide. The second victim questions came at the end of a very lengthy survey, so it's certainly conceivable that nobody wanted, some of the respondents did not have the endurance to complete it. Furthermore, the information is personal and vulnerable, and although the survey was anonymous, many physicians may not want to disclose this type of information within a workplace survey. We're also lacking granular details regarding the adverse events, the frequency in which the physician is experiencing these events, and the coping mechanisms that they previously utilized. Lastly, there may be physician reluctance to adopt the term as victim, and there may be a reluctance to use the term a second victim within the physician after having a specific patient event. So we feel that these results may be underreported. In conclusion, at least a quarter of select physicians have disclosed second victim experiences. Specifically, patient-related burnout was particularly evident amongst those with second victim syndrome. This information provides a valuable starting point for institutions to offer non-mandatory coaching or counseling for physicians in need. Thank you, and I'll take any questions.
This paper is open for discussion.
Excellent topic. Pamela Zimmerman from West Virginia University. I think that as we're more aware of complications that occur, sometimes in the operating room, it is very difficult to deal with death and dying. Possibly it was beyond the physician's control, and at times it is at the hands of the physician that a mistake could have been made and a patient will pass away, and then the physician continues to, deal with that after the operating room. Is there any, in your study and as you're looking at this, what about incorporating this into our training as vascular surgeons are going through training to learn how to cope with this, to learn how to identify it? And because I think a lot of people do not identify, so do people know how to identify? And then once they identify it, even as a trainee, when you're dealing with death and dying, do people know where to go and what to do? And are there services that are set up for trainees to learn more about this in training?
Thank you for that excellent question. So within our institution, we actually do have survey data pertaining to trainees with this same question asked. We haven't yet analyzed it or reported it, but we do have that information. In terms of established counseling programs or training in place for trainees on how to cope with this, I haven't seen anything specifically reported in the data specific to second victim syndrome. Again, I know personally from my own institution, we do have the junior residents meet with a counselor to try to discuss how to manage their feelings of loss and adverse outcomes and time management, et cetera, during their early years of training. But it certainly would be valuable to know if this had been incorporated elsewhere specifically.
Yeah, thank you for the presentation. It's a very interesting talk. I do think calling it victim syndrome is pejorative, and probably nobody's going to identify. You need to change that and come up with something that's a little bit more acceptable to the surgical community. I've always said the longest walk is from an operating room to the waiting room to talk to a patient whose family member you've lost. And traditionally, we've not taken our trainees with us to do that. Partly because you're embarrassed, partly because you never quite know what that situation is. But it's one of the things I've really tried to do, and I think it's a very practical thing to do, is instead of leaving the resident to close the wound or something like this, take them with you and be in the set, because they don't get any experience with that. And so often you go into practice on your own. The first time you ever got to deal with this, it's your patient. And so I do think that's a very simple thing that can be incorporated. As uncomfortable as it is as an attending, it's a good thing to do. But thank you.
Thank you. I completely agree. I think that would be an excellent way to introduce this aspect of your career to the trainees before they end up having to do it themselves independently. And yes, it has certainly been a limitation to utilize the term second victim syndrome because many do not identify as victims and they find the term somewhat offensive.
I was curious if you could comment on which way you think the causality is going in the survey, because I think you mentioned that respondents who reported certain aspects that were higher on the burnout scale were more likely to be, quote, second victims? Or is it kind of the other way around, where people who have experienced this adverse event are then more likely to experience these downstream effects?
Yeah, that's a very good question, and there's certainly, I can tell you maybe what I think, that maybe you would consider that there would be a selection bias in the people who were willing to complete the entire survey and answer these questions clearly feel a little bit more passionately about it than those who just skimmed right through them and didn't maybe complete it that much. But based on my research and how prevalent second victim syndrome actually is, call it whatever you want, PTSD, how prevalent that is within the medical and surgical community, I do think that 24% of our respondents is an underreported number.
Dr. Pierce, I'm so sorry to cut you off, but I'm getting daggers, so we have to stay on time because this discussion is going to move on, I think. Thank you so much for that nice presentation and good discussion. Dr. I'd like to invite up now to identify for us individualizing interventions to prevent and treat this phenomenon. Thank you, Dr. Ait.
Yeah, thank you very much. I hope you noticed some of the statistics on her slides showed those of you who are not able to sleep, like all of you that got up early to come to this session, are particularly at risk for second victim syndrome. I have no financial interest, unfortunately. I have used this term over the years, and I don't know why. Maybe it's just because I've had a lot of bad outcomes, but this has been an important topic to me for several years, and I think it's really one of the most crucial things that we don't really include in surgical training. How do you respond to adverse events? We've learned to just walk it off, stiff upper lip, just ignore it, and as trainees, you think, well, that's what I'm supposed to do. And I think the idea that these things do have an impact on us is pretty important. I've used this image for several years to sort of describe a vascular surgeon after a death in the operating room or an adverse event. Just like these docile, happy little manatees floating around in these tidal pools in Florida, their most common cause of death is getting hit by a motorboat. Every one of us has had the feeling of getting hit by a motorboat prop with a bad outcome. If you haven't yet, you will, I can assure you that. And it's something that you have to learn to deal with. And just like these manatees, if you take too many prop strikes in a short period of time, you may just belly up. And learning how to allow these wounds to heal and to go on and be productive, I think, is really, really critical to being a vascular surgeon. I thought there were some really nice points that we just heard. 28% self-identified as second victims. I can guarantee you the number is higher than that. That's a self-admission. Nobody wants to admit it. Patient-related burnout was particularly evident among second victims. Official debriefing, individualized counseling or coaching to cope with the event were top resources. Mandatory meetings with psychiatry and psychologists was at the bottom of the list. So we had a program at Baylor in Dallas that was the peer support program. It was called SWADL. There wasn't a vascular surgeon, a surgeon in the institution that would ever go to SWADL. We don't have the personality to go to that. Nobody ever used it. The literature is full of stuff about this. And unfortunately, the term, as Alan's pointed out, is just built into the literature. It's called second victim. None of us think it's a really good idea. First of all, we don't think our patients are victims. They may have a bad outcome, but the idea that they're really a first victim is really unappealing to any of us, and none of us like to see ourselves as victims. We made choices, and we live with those decisions. This was a good study that was done a few years ago in Boston. They interviewed a bunch of surgeons at 3 different hospitals for have you had intraoperative adverse events, and what was your response? Not surprisingly, a lot of sadness, anxiety, anger, guilt, those kinds of things. I found most interesting in this survey, this 10% that had no feeling whatsoever, the sociopaths. These are the people you don't want operating on you for sure. What did they conclude? Adverse events are frequent. They're inevitable. They're reported by more than 90% of surgeons. They have a big negative impact on you, and there are inadequate or non-existent support systems in reality. This is another summary paper that was done a few years ago. It's a really good paper. 90% of surgeons report emotional impact of adverse surgical outcomes, just what all of you have felt. These sense of interference with sleep and cognition and leisure, crisis of confidence. Every one of us has had a time we went home, sat in the living room, had an extra cigarette in the middle of the night in the dark thinking, man, I got to quit. I can't do this anymore. I am not able to do this kind of stuff. I worked for a guy in Dallas, Bill Fry. He was the chief of surgery there. Very well-established vascular surgeon, did a lot of renal artery bypasses. He had a 14-year-old kid when I was a fellow, and he did a renal artery bypass. Bypass bled, guy died. He never did another renal bypass after that single case. He was a senior guy. He could kind of afford to do it. But for those of you who are younger, it affects everybody, especially, and in fact, it's probably worse at the edges of your age. When you're young, you're more affected, and even as you get older, it becomes worse because you think you should avoid these bad outcomes. But you trip up, you're vulnerable throughout your career. This has implications beyond just the individual. You talk about altered practice patterns so that people then start to base your practice on anecdote rather than evidence. It changes how many doctors we have because you don't have the same number of surgeons applying the appropriate care. What do you do? Think about it to yourself. What do you do in response to an adverse outcome? You all have got some kind of coping mechanism. Some of you keep it to yourself. You exercise. You go get on a bike and ride around. You do a little more meditation. You talk with colleagues. You confide in your spouse. You can publish it. That's a great one. Make a case report out of it and rationalize it and get a little bibliography out of it. Or you drink too much. I'm sure nobody in this audience would turn to that as a solution. Why don't we seek support? What's all the reasons you just heard? We're not going to turn to somebody and ask. Particularly, we're worried about negative impact on referrals, paper trails, stigma associated with mental health issues. So it's all the reasons that none of us turn to help. When we do look for help, where do we go? We go to our colleagues, number one. We don't go to institutional resources. We go to our partners. We go to people that know what the problem is. We sometimes go to our spouses. I've got a very sympathetic spouse. Sometimes, though, if I'm telling her a story about it, it's almost like talking to my Great Dane. She's very thoughtful, and she looks at me. She's got big brown eyes, and she nods her head, and she's sympathetic, but she really doesn't know what it's like to be in the operating room and knowing a case is going south, and there's something that bonds us together in a way that no one else outside of that operating theater will ever feel. What we don't do is tend to go to therapists. What do surgeons want? This was actually a survey done by some pediatric surgeons who've been sort of ahead of the curve in developing these support programs. Peer-to-peer, confidential, 24/7. You don't need an appointment 2 weeks from now to talk to somebody about a death on the table today. You also don't want just spot check. Somebody calls you from a peer support program, says, hey, heard you had a bad case, you want to talk about it, and then never hear from them again. Partly, surgeons, we want solutions. We want help in how to get out of this mess. What do we do next? And we really do want competent critique. We want to be better. We want to learn. Would you have done the same thing? What would you have done if you faced the same problem? We don't want judgment, but we invariably want to be better surgeons. So, adverse clinical outcomes have a significant impact on us. Surgeons rarely seek help, and we prefer to confide in colleagues. And our charge today was to say, if you take that array, that problem, and now we ask, how does it affect women? How does it affect minority surgeons? How does it affect surgeons from international medical graduates? People who don't look like the majority of surgeons. Are they even under more scrutiny? Are they less likely to appeal for help? And I don't think there's hardly any data in the literature to answer these questions. My impression is that that's probably true, and there are some data that sort of help to suggest that. There's an epidemic of racism in peer review. The whole peer review process may be contaminated. That there are increased number of adverse medical staff actions against physicians of color. Under the guise of quality care, multiple examples of anti-competitive and racist motivations. And there's a lack of diversity at the level of most hospital leadership and peer review committees. Women surgeons are punished more than men for the exact same mistake. This was interesting. PCPs, if a woman surgeon has a death, has a bad outcome, she has a class effect on other women referrals. Whereas for men, it doesn't spread. It affects that individual referral, but not treated as a class. That's really sort of fascinating information. And then this whole issue, this is a paper kind of about how women and hospital employees interact and how it's obviously more challenging. And the chance of getting, in our program it's called MIDAST, sent into the anonymous reporting system. Women surgeons feel a higher chance that they're going to get reported to the MIDAS system because of departmental conflict and problems in the hospital. Participants see personal and professional implications, including self-doubt, depression, and frustration in relation to how they deal in the hospital, more so than men. And this was one last one, gender differences in surgeon burnout and barriers to satisfaction. Both male and female faculty, there was a lack of control with work-life balance. For female faculty, the major theme of gender bias in the workplace as a risk factor for burnout was prominent. Oddly enough, in this survey, male faculty struggled more than their female counterparts with guilt over complications in second victim. The reality is we don't know how this works. There's been unbelievably little data, and it's just begging to be looked at. So I kind of think about it like this. There's tiers of support that we all need. The first is most simple is self-support. And that is this concept of self-compassion, which really smart people that know more about this than I do use these three terms of mindfulness, common humanity, and self-kindness. And I think we can all agree that that's something we could do better at. The second thing is this, to me, is really important, is peer-to-peer, what I would call battlefield first aid. We all have the capacity to stop the bleed when one of our colleagues has a problem. Put a tourniquet on, shove some morphine in, and call for a helicopter. Everybody in this room can do that, but we're afraid to. We don't know if it's okay to talk about. We don't know if it's okay to reach out. But I'll tell you, it is. There's peer support programs in almost every one of your hospitals. Some are department-based, some are institution-based, and even some are society-based. And the SVS has worked for several years to try to develop a good peer support program. It's more challenging than you think. And then I'm not degrading the importance of real life, real people who go to real therapy when they need it. So the question is how to individualize intervention to prevent and treat second victim. What should you do when a colleague experiences a bad case? I would say this, do reach out, do listen, do offer support, do provide acceptance and trust and assure confidentiality. Don't isolate. The worst thing you can do is say somebody has a bad result and say, well, we're going to change the schedule and not give them difficult cases. That just makes you feel more paranoid. Now you're worse than you were off before. The other thing is, talk about it. Don't pretend and treat them like they're radioactive. So we don't want to talk about this. That's more dangerous than just saying, hey, I heard you had a bad case. Is there anything I can do for you? Reaching out is probably the biggest message that I would deliver today to all of you. Don't try to fix it. It's not your job to come in and fix it. Don't give solutions. Don't judge. If somebody says, hey, what would you have done, though? It's perfectly fair to say, I might have tried a different way of approaching that. We want to be better. Don't give false reassurance and say everything will be fine. It may not be. You may get sued. You may lose a big case. We don't know what's going to happen. False reassurance is worse than anything. We've developed kind of a peer toolkit, and I'm just going to go through it real quick, but the mnemonic is PEARLS, P-E-A-R-L-S, and it basically says if you or one of your colleagues is in a mess, you've had a bad case, and you're sitting in the locker room, you're thinking, what am I going to do now? How to kind of order your thoughts to make this a little bit more simple to deal with. The first priority is what to do with the patient. Assuming you've got a survivor, you may not be the best person to take care of this patient. We've all seen situations where people abandon patients. Anybody's had a stroke after a TEVAR, it's hard to go in the room. You just want to walk by, have the resident give you the report, and run down the hall. I've done it, and I'll admit it, that there's times there are just people I don't want to go in and see. But you got to make sure the patient is effectively cared for. Make the referral if you need to, change doctors, change hospitals, but make sure P is number one. The second is figure out where you get emotional support. All of you are going to have a different way to do that. I would recommend to you to reach out to each other. I really do think this concept of battlefield first aid is really important. Put a tourniquet on, give them morphine, send them, get a call for a helicopter. We can all do that. How do you go about disclosing the problem to the family? Bob Batson in LSU had a great idea to me that I've used over the years. He said when one of his faculty members has a bad outcome, he will go to the bedside with them to have the conversation with the family or the patient. It does three things. One, it tells the patient, this is important. I'm the chief of surgery and I'm here. We're not just forgetting about you. Two, it tells your faculty that you care about them. The third thing it does, it provides a witness in the room to the conversation that was occurred so that at a later point, the patient says, hey, the doctor came in and he said he killed my mother. And at least you have someone who has your best interest at heart that's in the room that says, wait a minute, that's not exactly the way the conversation went. But I think that's a good idea. And think about how you have that conversation. We could have a whole session just on that. Let me back up here. There was two other things. Yeah, the other thing is the importance and the therapeutic benefit of review. People have downgraded M&M, say, oh, it's terrible, it's punitive. It's not punitive. M&M can be a very therapeutic process when you've had a bad outcome, and we need to keep it in our programs. Lastly, I won't mention too much about legal issues. I see Bill over here. We're all worried about, are you going to get sued, what to do? It's a whole chapter, but it's a piece of the puzzle that you have to kind of think about as you're going through this, miserable situation. And lastly, particularly in relation to your colleagues, you got to be sensitive to people who are at risk for self-harm or substance abuse, and be alert to say, hey, maybe you do need to get referred to somebody, because we're all vulnerable. So in terms of peer support, I want you to think about this in two ways. One is look at staff services as peer support and peer review. And I think the peer support issue is clearer. You got to ask the question to me was, what should I do when I leave this place? Go back to your program and say, do we have a program? Is it utilized by surgeons? Does it meet surgeons' needs? Is the program specialty specific? I don't want to talk to an orthopedic surgeon. I want to talk to a vascular surgeon when I've got a problem. Do these programs meet your needs, and particularly those of sort of the non-majority or underrepresented surgeons? Self-compassion education in all programs, and I think the suggestion came up before. I think this, the concept of peer support between each other, collegial support, battlefield first aid should be part of our training for all residents. That's part of what we do. It's why we're at this meeting. It's what we love about this meeting, is the collegiality. And in regard to peer review, it's kind of a separate issue, but we really do need to make sure that the peer review process is not biased against women or non-majority surgeons, and make sure that there are some evidence that there are inappropriate referrals that are really economic-based in other ways that makes the peer review process inherently biased. So I'm sorry I took too long and I'll shut up, but I think it's an important topic, and I know a lot of you have feelings about this, and I really appreciate the opportunity to talk to you this morning. Thank you.
Thank you, Dr. Ait. Dr. Mansour.
John, this is a great talk. I applaud the program for putting this sensitive topic on the program. And what I wanted to ask you as a corollary to what you just said is, should we have a peer support for physicians or surgeons who get sued, who kind of go through this emotional event in their lives, especially early on in their careers, where they don't know what to expect and they think, oh, my career is over, I'm just, they're going to yank my license, and et cetera, et cetera.
Yeah, that's a great question, Ash. I mean, the whether you get sued or not, in some ways, is not related to how deep the prop strike is down your back. In other words, some of these cases, you have an injury where you didn't really cause it. It's just a natural history thing. But you may still have significant impact. I mean, I've had people that got, hyperpigmentation from injections and feel bad about it as much as a death, an expected death from a ruptured aneurysm. So I think the magnitude of whose responsibility may be quite variable, and whether you get sued or not may be quite variable. But there's no question that if you get sued, that's a pretty deep prop strike, and everybody who's been through that knows that's a pretty deep one. And the whole medical legal thing is pretty damn complicated. I see Bill out here and Dr. Tracy and some of the other lawyers in the group. We get this conflicting information. Don't talk to the lawyer because they may get subpoenaed. Look, we talk to people all the time about cases. It's important to us. The narrative is important. The importance of telling your story is really important. And the same thing is true for people that are in lawsuits. I totally agree. Being able to identify an expert witness that'll help you, that's a really important process. And it's where we as colleagues can help each other with that process. Yeah.
I apologize. I think we're going to have time for just one more question. Dr. Hignorani?
Just a short question. I know this is a big topic, but could you just give a few words on the punitive nature of some M&M and or the peer review process, and how to try to change that culture? Because sometimes when you have these complications, you can deal with the family, you can deal with the patient, you can deal with yourself, but sometimes dealing with everyone else around you, how they see you, how they look at your case, can be equally difficult and equally damaging?
It's a great point, and I think all of us have an obligation to figure out, because we do want to be better. Reviewing the process is really important. That is, the debriefing. You know, the military's done this for ages, right? If you go out and try to be a better fighter pilot, you have to come in, develop a plan, you go fly the mission, and then you come back in front of a panel and say, what did I do good, what did I do bad? Not in a judgmental forum. You know, and I think M&M can be very therapeutic if it's in a positive way. And it's incumbent on all of us, especially those of us who are in leadership positions, to make sure that our institutional review process is in fact unbiased and is in fact therapeutic and is getting to the end result that we want, which is better care for everybody. And it is tricky. And I think if you have a lot of these, there are times where you, particularly in situations where you have shared expense model groups, that can be a real challenge where your so-called colleagues are actually your competition. I don't have an answer for it, but it's something that we all have got to fight all the time. Thanks very much.
Thank you, Dr. Ait.
I'd like to invite up our next presenter, Brittany Montross, who will talk to us about an improved method of teaching faculty evaluation. Oh, Dr. Harris will be presenting.
Unfortunately, Dr. Montross had a family health emergency, so I'm presenting for her. So before we start, no disclosures. I'd just like to have you think about two questions. For the faculty, how many of you have ever had feedback from trainees that's made you change how you teach? And for the trainees in the room, how many of you have been honest on a routine basis in your evaluation of your faculty? So faculty evaluations are a challenge, especially in small programs. The major concern is lack of anonymity. So even though it is confidential, we all use these online forums, everyone's afraid they're going to know it was me. And so they don't want to be honest. So I decided at some point that we needed to make a change because the faculty evaluations were not really working. And we decided to go from just having the online to have a system similar to what we do in our CCCs. So we went to a semi-annual collective model where I instituted in 2021 having all of the trainees in a single room with no adult supervision. So no faculty, no program coordinator, just the trainees. And I gave them a charge. I wanted 1 positive and 2 areas for improvement for all core faculty. They collectively gathered the information, and the administrative chiefs then presented that to me, which I then dispersed to the faculty. Afterwards, after we'd done 3 cycles of this, I wanted to assess whether or not this was actually working because I thought it was a wonderful idea, but not all of our wonderful ideas turn out to be wonderful. So we did use SurveyMonkey to anonymously survey both the trainees and the faculty to see whether or not it was actually achieving what I hoped it would achieve. So results. Previously, when we were just using online evaluations, most faculty either felt that they got feedback annually or not at all. With a collective model, the vast majority felt they were receiving the feedback semi-annually. Of course, when we asked trainees about the prior evaluations, when you looked at online, 40% did not feel they were confidential. And when we asked honesty, 40% were either not honest or only partially honest in their evaluations with our standard evaluations. And again, when you ask why, fear it wasn't confidential, fear it would be used against them, or thinking it wouldn't make any difference whatsoever in the faculty's behavior. When we went to our new collective model, 100% of trainees felt that it was confidential, and 100% of trainees said they were honest in their evaluation of faculty. Huge change. So the next question is we looked to the faculty and said, did they feel that the feedback on them was accurate? While there were a couple that did not feel it was accurate, the vast majority felt that it was accurate or partially accurate. More importantly, we asked, was it helpful for them? And again, the vast majority thought it was either helpful or at least partially helpful. And what I think is most important, we had about 80% of our faculty made behavioral changes in how they were teaching based on the feedback they got from trainees. So next question, did the trainees see this? And the answer is yes. The trainees saw a significant change in faculty behavior based on their feedback. And more importantly, it was positive change. So it wasn't, I'm going to get them, they thought I was bad before, now watch out. It was actually a positive change. We then asked, what is the preference for feedback going forward? And both for the trainees and the faculty, the vast majority preferred having the collective model. Some have preferred to also have online, so we've maintained both. In the event that there is an individual who doesn't feel comfortable in the group setting, they still have the option of giving the feedback online. Comments from the faculty that we did get that we'll discuss is some of them wanted to have the opportunity to talk with the trainees or a designated trainee about their negative feedback so they could kind of debate the issue, I think. Some people commented that change is hard, which it is. There's no question about that. Many people felt that this is certainly better than the numbers. And I don't know about you, but before we would get a number, either on a scale of 1 to 10 or 1 to 5. All right, you're a 4.2, you're a 4.5. What does that mean? And the feedback commentary was usually not very helpful. And again, the faculty thought it was potentially going to improve their teaching. And trainee comments is they don't like the online forms. Again, they just don't feel that those are very effective. So conclusions. Standard online evaluations are not always useful as they are. They're time consuming and they're not very accurate. And I think most of the faculty in the room would admit that they have not gotten very much that has enabled them to become better teachers. Think about this. Teaching is a competency. How many of you were actually trained how to teach? Most of you probably were not. How many of you would like to be a better teacher? Can I actually have a show of hands? Who would like to be a better teacher? All right. So we need feedback because we can't improve if we don't know there's a problem. So we do feel that the collective faculty evaluation may be more useful. It will give people an area for improvement where they can improve. And to give you an idea of some of the areas for improvement, I've listed them on the slide here. There were operative or clinical issues, communication issues, professionalism issues, not being timely, not being tech savvy, lack of academic involvement. And thank you.
We have time for one question.
Excellent topic. Just in the other aspect, have you considered, are the faculty meeting and giving collective recommendations for how the trainees can improve? I know faculty at times do not like to put negative things on paper, and sometimes it's hard to give negative feedback, even in a constructive way, to our trainees. Have you considered looking at it in the reverse as giving constructive criticism from the faculty as a group rather than an individual evaluation?
Yes, I think that's an excellent point, and we do something like that. So we still have the online monthly evaluations or end of rotation from faculty, but when we do our CCCs within vascular, that's when I really gather all the comments because you're right. Faculty do not also want to write things down because they don't want to be the bad guy. They don't want retaliation of the resident isn't going to help them. And in our general surgical program, they've gone to having a surgical educator meet at the end of the rotation with the faculty because, again, in writing, the evaluations were not really helpful. And this way, that individual collates the commentary from all the faculty on the rotation and is able to put together something that's useful for actual improvement. So, thank you.
Thanks. Unfortunately, we don't have any more time for questions for this.
Thanks.
Our last presentation, oops, sorry. Our last presentation is an invited presentation. David Rigberg will talk to us about tailoring trainee and faculty evaluations to address individual needs.
All right, thanks everybody. I'm pretty sure it's a very poor idea to go last, especially if you have to follow Dr. Ait, but we will get through this. I was asked to give this talk, Tailoring Trainee and Faculty Evaluations to Address Individual Needs. I thought that was a lot to bite off for one talk, so I shortened it to Tailoring Trainee Evaluations to Address Individual Needs, more on the trainee side. So what is the problem? So there definitely is a problem. This is not just all anecdotal. This is a study looking at ACGME milestones for internal medicine residents. It examined race, ethnicity, and performance assessments for over 9,000 internal medicine residents and compared these over the years of training. The top half of this is for the Asian residents. The lower half is for non-Asian minority residents. And you can see the trends are all towards favoring white students, although there is some improvement in this statistic as they get further into their training. What the authors concluded in this study was that in the second year of training, the white residents received increasingly higher scores related to their Asian and non-Asian minority counterparts. And these really peaked in the second year. And even though there was some improvement of this by the end of these residents' training, this had likely a large impact on the ability of residents to get jobs and to get fellowship training, et cetera. Well, what else do we know about milestones? So this is another article. Also, these are both from 2022, so recent literature. Looking across the competencies, you can see a chart comparing minority residents versus their white counterparts. You can see across these competencies clearly higher scores for the white residents across all of these. And what's even more fascinating, and sort of in contradistinction to what we heard a little earlier in the talk on autonomy, is that there are actually huge differences, at least in this study, using the milestones with internal medicine residents, if the evaluations were performed by male or female faculty. So the first two bars for each of these competencies are evaluations for the minority versus non-minority residents by male faculty, and then minority versus non-minority residents for the female faculty. So how do other industries deal with these issues? So Dr. Wu asked me to make this talk not just a depressing, oh my God, look how horrible the world is, but what are some plans of action we could actually take? And so I thought I would look and see how the business world deals with some of these as compared to how we're dealing with it. So this is a study from the Harvard Business Review from just 2 years ago, where a firm realized from their performance surveys that less than 10% of people of color had a mention of leadership in their evaluations, while greater than 70% of white women had such comments made. And these types of comments, they noted, were really predictive of higher competency ratings across the board. And in their analysis, they came up with a variety of categories that really were problems in making evaluations. And a lot of these you'll see are just sort of common sense and things we all see. So one of them was the idea of having to prove it again. So the minority employees and women were frequently judged more on their performance versus the white men, who were really judged on their potential. The idea of the tightrope, so there was a narrower range of acceptable behavior from minority and female employees. They would often be labeled as aggressive or difficult for behaviors males otherwise would not be. The concept of the maternal wall, so women in particular were assumed to be less ambitious in their career goals. And there are certain stereotypes. So the female employee might be labeled as the office mom and have responsibilities that went more in those sort of categories than what their male counterparts had. And across all of this, standard racial stereotypes frequently were a problem in evaluations. All right, so this company didn't say, well, that's the way the world is, we're going to leave it alone. So they decided to put a lot of focus on, okay, what can we do to fix this? So one of the things they did, we'll all be proud to see, was they went from open questions to competencies, so something we in medicine have embraced for some time now. But in addition to having to work with a scale of competencies, they had to give 3 pieces of supportive evidence for each comment, essentially, that they made about their employees. And this avoided one of the big problems, which is known as the halo horns effect, where basically you generalize strengths in some groups, i.e. typically white men, and then focus on the weaknesses in other groups, i.e. women and minority groups. They also instituted workshops to explain the changes and to institute them throughout the firm. And they made sure that they broke the comments into the categories we've previously discussed so they could identify where the problems were. So what were the results? Well, in a short 2-year turnaround, there was a dramatic increase of the number of leadership mentions for people of color. There was a huge increase in the comments that gave constructive feedback. Negative personality comments were way down. And just as an example, they added takes initiative as one of the competencies. As a comment, there was a 19% of this in people of color's evaluations at 1 year and up to 94% at year 2. I think the most interesting part of this project and study was that they realized it was an iterative process, so it was not one and done. They did note some of the problems persisted. One of these, which was really pervasive and is still pervasive in the legal and business worlds, is the women are wonderful problem. So you'll get a comment that says, she is great, which looks really nice and is basically a worthless platitude that doesn't lead to promotion or excelling in business. They also noted a persistence of the prove it again problem. So people that were in the minority or women had to repeatedly do things correct to get the credit that the white men essentially got, and that there was a persistence of these type of housework comments. So they've continued this project and will continue to publish on it. And I think there's a lot of good lessons in that. What are some other issues that we can learn from the business world before circling back to surgery and vascular surgery? So one is the idiosyncratic rater effect. This surprises none of us, right? When you're filling out evaluations, there are huge individual level variations based on who the reviewer is. So this has to do with how we as reviewers interpret criteria, how judgmental an individual is, and then just our inherent cognitive and social biases. And if you look in the business literature, there are fascinating studies showing that over 60% of performance ratings really are more reflective of the assessor than the assessed. And that's really something to keep in mind, and I think surprises none of us if we think about it for a second. The other thing that's fascinating is this use of broad questions. So since we were medical students, we've been taught the importance of using broad open box questions to get information from patients. It turns out, as you would expect, these are absolutely horrible when it comes to evaluating people. So if you ask a question like, how does the resident's performance meet your expectations? It's way too ambiguous, and whenever we as people have ambiguity in these types of questions, it essentially leads us to fall back on stereotypes and our biases. Objective questions, of course, aren't a panacea, and variations in scale is the big thing I think of. How many of you, when you sit around your table, I know at UCLA we have our interview day and then we sit around and one person's 3 is another person's 10, right? There's a huge variation, and we'll talk about that more in a second, some of the ways to combat that. So it's interesting if you look at the business world. I think as vascular surgeons, we look at these bias issues and evaluation issues sort of as social warrior issues. You know, we want to do it. We want to fix this because it's the wrong thing for people to be treated unfairly. The truth is, it's also bad for society. And in business, you know, it's a very bottom line type of environment. And so they realize that if we aren't promoting the right people and recognizing talent, we're basically cutting off our nose to spite our face. So in the business world, there's been a lot of move to correct these problems so that they promote the correct people and do what's best for their bottom line. I just want to spend a second on bias. There are probably some of you in the audience who are experts on biases. There are a million types of bias, and the more you read about it, the more and more interesting it gets. I thought the most fascinating thing was discussing self-rater bias and just looking across cultures. So the American proverb, the squeaky wheel gets the grease, versus the Japanese proverb, the nail that stands up gets hammered down. And you could imagine the difference that could have for an evaluator coming from one of those two perspectives, or the resident coming from one of those two perspectives. So this is all very important stuff to keep in mind. All right, so in the business world, what type of solutions in general do they come up with? Well, like with us, they provide unconscious bias training to the people that are in charge, try to use formal prompts when they're doing evaluations that encourage as much objectivity as possible. Clearly communicate performance criteria and set development goals, which we are not really great at, even though we try to give our residents training goals. Use specific, well-defined rating scales. And then what I found fascinating was limiting the rating scale. So there's an excellent article where a company that had a huge problem with the gender gap in evaluations went from a 10-point scale down to a 6-point scale. So just in limiting the range, they completely eliminated the gender bias from their annual reviews. And then the other important point they make is to involve multiple perspectives in providing evaluations. And we can pat ourselves on the back here for incorporating a lot of 360 reviews in the way we look at our trainees. Okay, so circling back to vascular surgery. So what have we done? Are we good at this? Well, yeah, we've moved from open, broad-based questions, right? We use milestones, and we try to do a lot of this correctly. There was a question asked earlier about EPAs to Mal, and I think this is probably one of the big answers. And I really like the fact that vascular surgery has embraced this greatly. Under Bridget Smith's leadership right now, we are working on the first set of EPAs for vascular surgery. So I'm sure, given the fact that you all came to an early talk, most of you already know all about EPAs if you're interested in education. But these are professional practice activities that are defined as tasks or responsibilities that are very easy to define and define as being completed appropriately. And if you compare EPAs to competencies that we currently rely on, again, it's very simple. EPAs represent actual day-to-day work that we do, whereas competencies, if you look at them, they really tend to be a little bit wishy-washy and abstract. So in creating these EPAs, we basically use a general framework, and this is just the example from general surgery using, there's a preoperative phase that you might look at, an intraoperative phase, et cetera. And then it's not that we would be getting rid of competencies, so these are then mapped depending on the particular activity. And it makes them a lot more specific than as I'll show you in a second, rather than having something like the resident demonstrates proficiency in handling of instruments, et cetera. So this would be the hepatobiliary one. You know, the resident is able to describe the boundaries of the hepatocystic triangle, understand the relationship between the gallbladder, et cetera. So they're much more checklist, which really would go towards eliminating bias, right? It becomes much less important who the person is and what your biases would be if you're just looking to see that they actually did certain steps. All right, so do we have any data about APA so far? We actually do, from the general surgery literature. This is another recent article, just came out in December. So essentially, faculty assessments, there was an elimination of a gender bias in EPA levels between male and female residents that we were seeing in competencies. So right off the bat, we have some very promising data on the role that EPAs can play in eliminating these evaluation biases. Interestingly, and we heard about this in that excellent talk on autonomy, female residents rate themselves lower by nearly an entire postgraduate year compared to their male residents, likely either due to men overrating themselves or women underrating themselves. I'm guessing it's a combination of both. And this difference in self-assessment is really related to a lot of different factors that we don't need to go in right now, but we definitely need to be aware of as we figure out how we're going to use EPAs going forward. So in conclusions, there are documented issues in many types of evaluations. This isn't just people guessing, oh, there might be a problem. There is hard, objective data. This is a problem across many fields, and we owe it to ourselves as vascular surgeons and to our trainees and the public to identify and fix these problems. This is going to require following the evidence, evaluating the results, and most importantly, continuous adjustment. I think the fact that vascular surgery is embracing EPAs may go a long way in mitigating some of these issues. And thank you very much.